everyone. This is ideaXchange, where the leaders behind mission driven organizations share the ideas that are actually moving the needle. No theory, no fluff, just the strategies, decisions, and hard earned lessons from executives who are actually doing the work. Idea Exchange is brought to you by 108 Idea Space, the digital strategy and technology partner for associations, nonprofits, and regulatory bodies across North America. In the last 18 months, the global health funding architecture that has held since the 90s has come apart. US aid has been effectively dismantled. The Canadian government has cut 2.7 billion from foreign aid. The Lancet is now projecting 9.4 million additional deaths globally by the end of this decade if the current trend holds. Over the last 18 months, at least about 81 international NGOs have already closed their doors, at least one of the offices. The middle of the sector is hollowing out. Inside that picture, our guest today has been running a small Canadian charity that sits inside one of the most respected global health movements in the world. Not a branch office, a separate Canadian organization with its own board, its own donors, and its own decisions to make. And he's been making them through the worst funding shock the sector has seen in a generation. I'm sure this is true.
Mm.
His name is Mark Brender. He's the national director and CEO of Partners in Health Canada, the Canadian sister organization of Partners in Health, the global health and social justice movement, co-founded by the late Dr. Paul Farmer. Mark opened the Canadian organization in 2011 and has run it ever since. He also sits on PIH's global leadership team, which means he carries the Canadian voice into a movement now operating in 11 countries. Mark, welcome to Idea Exchange. Before we get into all of this, why don't you take a minute and introduce yourself to the audience in your own words? Who you are, what PIH Canada is, and what's actually on your desk right now.
Yeah, thanks, Ashish. It's such a pleasure to be here, and to having this conversation with you. I guess I have a bit of an unconventional background. The super short version is started a career in journalism, sports journalism, actually, and then was very fortunate about 15, almost 20 years ago to get into nonprofit world through a sport for development organization.
Mhm.
And then really kind of learned the ropes of nonprofit through kind of marketing, communications, fundraising over time. And then, as you say, have been just so lucky to join an organization as of 2011 that within the global health space has really helped prove what's possible, that it is actually possible to deliver high quality care anywhere in the world, and has really set out some systems and structures to be able to do it. And yeah, look forward to diving into all that. And then really since 2011, very slowly, but as you say, building up from one person to now 13 employees. And in a time of really huge need, as you say, we're really looking to think in every way about how can we accelerate and broaden our impact.
Definitely, and thank you, Mark. That sets the table well. Um, let's start. One of the things when I was learning a little bit more about your background, I figure it's a little unusual, as you mentioned, like sports journalist to getting into nonprofit and in the healthcare related nonprofit. So just walk us through, how does these pieces connect for you today in how you run and manage PIH Canada?
Yeah, I think the connection initially was really around communications, which is why I was lucky to be able to get into the space. In that working with way back when athletes, as a journalist, and then being able to develop relationships, and then helping encourage some of those athletes to get involved in kind of sport for development work. But I think if there's a common theme, it's probably around that notion of relationships, communication, interpersonal, because I think that's the main reason why PH Canada here is really around fundraising to provide the resources that our colleagues in Haiti and Malawi and Rwanda and Sierra Leone and so many other places to provide them the resources they need to serve their people and to accompany governments in their own countries. And I think, one thing I've learned a little bit over the years is in terms of fundraising is really built on relationships. And those relationships are long term and take time and are really on kind of donors' timelines as opposed to our own. And I think, that kind of philosophy is really embedded in the work of Partners in Health as well, which is why it always felt so right to me, is in that it's not about external timelines and saying we're going to go in 3 years, we're going to accomplish X and then we're going to leave. It's really how do you make these long-term open-ended commitments, and the same sorts of things that build relationship with families or friends or loved ones are the same sort of relationships that I think organizations need to really gain respect and trust in communities. And so I think if there's a through line to what I've done, it's probably around that relationship piece, with a lot of learning over the years and a lot of benefit from working with many, many, many brilliant people, both on our team in Canada now and in the PH team around the world.
Sure. So that is something that, connects the dots. Was there something that did not connect as well? What did you find different from corporate, like transitioning into a nonprofit?
Um, I think it takes a long time really to learn what you don't know.
Hmm.
And there was a ton, the expertise in this sector. And I think that's something that, I didn't come from a traditional corporate background. Kind of journalism was a little different in and of itself. But I
Hmm.
think people that sometimes make a transition from the corporate world into nonprofit, there's an assumption that a corporate background allows you to know all. When it really doesn't. There is kind of a level of really deep knowledge and expertise, both in the sector from a lot of people who have, especially on the programmatic side, really what does it take to learn what is actually needed? Who do you learn from? Who has expertise? And it is not the same in the corporate world, where the people that have the most expertise are the people that know how to sell a product or know what it means to turn a profit of certain percentage. The people that we serve with the expertise are our patients. And I think in
Hmm.
many nonprofits, hopefully, the quicker you realize that the expertise lies in the people that you exist to serve, I think the better the nonprofit and the organization will be. And so the combination of kind of understanding that at a very deep level, and also really getting to learn and understand and respect people who take the resources and what does it mean to deliver into tangible impact, that's not easy. And it's much more complicated and requires much more listening and much more understanding and much more iteration, potentially, than I have a product. There is an audience for that product out in the world, and I'm going to go sell it.
Hmm.
So I think the level of intricacy around what it takes to, in our case, deliver healthcare, but also understand and address so many other needs about why people aren't able to access care, that we can certainly get into. But yeah, a lot of learning along the way.
Yeah, and for sure, in my years of work serving nonprofits, I've seen that quite a lot, like that passion and the attachment to the cause, which is not just the leaders, but it's common across the team, and I see how that is tied so closely to the success of the nonprofit itself.
Yeah,
Hmm.
yeah, I think so.
So that's amazing. That answers, how you got here. Let's spend a little bit knowing what PIH actually is. So for our listeners, um, so having some knowledge of PIH Canada's work and the global entity as well. I know it was formed by Paul Farmer's idea of accompaniment, which means long-term, open-ended commitment, not exit strategies, and it's fundamentally is a contrarian operating philosophy. How does that show up in how PIH actually runs its programs?
Yeah, no, it's a great question, and this is, one of the subjects I love the most because it really does flip on the head how often we think about what it means to help others. Um,
Mhm.
and I think with PH, the first thing that Paul and others that he was working with, really from the early 1980s in the Central Plateau of Haiti, was understanding that there's a historical context to why places and conditions are as they are. That often has nothing to do with the capabilities or the rights or the qualities of any people that have to be living in a particular situation. Um, and people that understand that best are the
Mhm.
people that are living in situations with what Paul called structural violence. So just as a quick example, where PH started in Haiti, it was this
Mhm.
community on top of a mountain where people were driven up the side of a mountain by a hydroelectric project that flooded their land, eliminated their crops. They had basically had this is in the 1950s had to go up the side of a mountain. They wind up in a place that is barren and remote, not good access to water, no access to food, no services. And so you can understand why there's going to be very poor health outcomes for all the
Mhm.
reasons of what we call social determinants that we just said. Um, and as a health organization and a social justice organization, what Paul and others and the many Haitians he learned from and also taught, what they understood very quickly was that that historical knowledge and context is critical to how you deliver healthcare.
Mhm.
And that's where the accompaniment comes from, is that, in PH's eyes, that word really means to walk alongside people, communities, individuals, governments, understanding that the timeline to kind of repair and work to address those structural conditions that cause people to be living in refugee camps, internally displaced persons camps, cities without infrastructure, where there are services that reach some people that aren't others. Those take a long time to be addressed, and that journey isn't going to be fixed in 1 or 2 or 3 or 4 years. But if we actually say that we are there to support people on their path as they see fit and address their needs, then we better make open-ended long-term commitments. Um, and so it really does turn on the head. We often think of a word like sustainability. And
Mhm.
what does sustainability mean? And for us, it means, if we have another phrase that says patients are our bosses. And no patient has ever said, if we ask, what do you really need? They said, well, whatever you do, I need it to be sustainable. No, they've never said that. The only
Mhm.
people that talk about sustainability are funders, people in the West, and it really means how quickly can we leave and move on
Mhm.
to something else. And so we think, we know a person's life isn't going to be sustainable if they've got in a severe car accident and don't have access to surgery.
Yep.
So how do we build those systems that actually allow people to be well, to have jobs, to have employment, to not have to make choices whether their kids pay school fees or whether they pay a user fee for accessing healthcare? That's part of what that word accompaniment really means that you said. So it's a pretty complex thing, but we think it's a model that has proved really, really effective over the past 4 decades.
Mhm. And I know PIH globally, through different agencies, you employ, 6,000 Haitians directly, as well as, the whole model is the having the community health workers. It's kind of the backbone of the field model. Now, if I put yourself or myself in your shoes, certainly I'm thinking, how do I connect the donors who maybe in this case are Canadian donors,
Mhm.
who would probably never see these people. How do you connect the dots between them? What do the funders miss when they don't understand that layer, and how are you bridging that gap?
Yeah, I think that's a great question. And often we talk, um, one of the things about PIH is initially in the early years, it really grew and developed out of, Partners in Health was based initially in Boston and in Haiti. And so many donors grew out of, as we said, personal relationships of Paul's, of Ophelia Dawes, who's another co-founder of this really tight team that built the early work. And so I think through those personal relationships, the kinds of people that were attracted initially and are still attracted to Partners in Health are people that want to understand that story. So they want to understand, why do you stay? How does this work that you say your commitments are open-ended when we know that many other people's models is we can't stay more than 5 years because we're supposedly creating dependency, which we disagree. So I think in one sense, the kind of people that we reach out to and that Partners in Health attracts are people that want to dive in intellectually to understand a theory of change and what that looks like. There's a whole nother kind of group of donors who sometimes may hear about us during disasters. So during Ebola in West Africa from 2014 to 16,
Mhm.
during the COVID pandemic, we were doing a lot of work. To go back, 15 years, the Haiti earthquake in 2010. So with Partners in Health, they hear about an organization that really has very strong capacity on the ground. They may give initially because they see a disaster and they rightfully want to help, and that's fantastic. And then it's on us to try to accompany a donor community as well and to say, um, this is our model. This is why we are able to be so effective during an emergency, is because we have these deep roots in communities that are driven not by people from Canada or the US or Europe, but by people from Haiti and people from Malawi and people from Liberia who deeply understand their communities because they're neighbors and friends. And those are the community health workers that you speak of. So I think it's always a bit of a balance about what narrative are we telling when. And I think that's where some of the donor data and the information helps us discern. We
Yeah.
have a lot of work still to do, but helps us figure out what kind of story should we be telling initially to allow people to enter in a way that makes sense to them. And then we can tell hopefully a longer story as they grow with the organization over time.
Absolutely. And we'll talk a little bit more about data infrastructure and stuff and how do you keep that afloat across 11 countries, let alone just Canada. But I see, that's the model in normal times, what we've been talking. Just wanted to explore, this model under stress, like the kind of stress we've been in the last 18 months is anything but normal. I think during our intro, I just spoke about USAID, being functionally dismantled, Canada cutting like about 2.7 billion from foreign aid, Lancet modeling 9.4 million additional deaths by 2030. From where you sit, what is the one thing the public conversation is still getting wrong about what this actually means?
I think one thing that we always need to keep reminding donors, ourselves, civil society, other NGOs, is that it's not NGOs' responsibility to deliver rights for people, right? And there's a little sign here at the back saying healthcare is a human right. We
Mhm.
believe that in Canada. We're very proud of it, that we believe healthcare is a right. And yet NGOs are not expected to deliver on that right. The governments are expected to deliver. And
Mhm.
so our job is really what PIH does, even in very, very difficult times. I think we're doing a couple things. One, we're proving what's possible because there's a whole very deep and long history of institutions, people, even funders, even Western governments saying we should be aspiring to some minimum package of care in poor places. We should be saying what are the basics that we have to do, and because somewhere is so poor, that's what only we need to do. And we
Mhm.
reject that entirely. If it wouldn't be good enough for your family or my family or our friends or our mother or father or brothers or sisters, who are we to say that that should be good enough for anybody in the world if we think that the conditions and way that where they're living in may be caused on by forces outside their control? So I think in this time, we are responsible for doing two things. One is to prove through our work that high levels of care are possible and high standards are possible. So no one can say this can't be done, which has been said many times over the years. It's why we do work about not just HIV/AIDS and tuberculosis and basic maternal care, but we do a lot of cancer care. We do a lot of mental health. We do a lot of chronic disease because that's what patients need in countries. While we are doing that, especially in this time, we need to be ensuring that from an advocacy and policy standpoint, we are making arguments about kind of global architecture in terms of global financing, global tax structures, what kind of foreign aid works and doesn't work that allow governments in places like Lesotho and Rwanda and Malawi to deliver on their obligation,
Hmm.
deliver healthcare for their people. And so we accompany those governments, and we also are advocating if we all say that, for example, African countries need to be more self-sufficient, and they are saying that because of what happened during COVID, the vaccine inequity, then we need to be pushing to create the global conditions where they have a fighting chance to do so. And right now, if you look at a country like Malawi, where they have federal health spending, so their federal Ministry of Health has less than $30 per person Canadian per capita that they are spending, compared
Hmm.
to Canada, where we're about $6,400.
Wow.
And so we see those kinds of differences, and we say, oh, they need to be more responsible. And we
Hmm.
see how ridiculous that kind of a statement is when so much of global architecture is preventing them spending on their public sector and hiring more teachers and hiring more doctors and hiring more nurses. Um,
Hmm.
so when kind of the global system is crumbling, I think it's our time to go deeper and double down on pushing for global policies that give countries a fighting chance.
Hmm. And I've also seen like over the last 18 months, like so many NGOs had to close their doors as well, especially because of the funding shock. What did you guys do differently? Like when you knew this is coming, like how did you approach that? Like the first 90 days, 6 months, which the others may not have done.
I don't know that we did anything different than anybody else, to be honest. I think all organizations are trying to figure out how they can be most effective, and we've had to, I guess, if you can say fortunate, we were less reliant on U.S. government funding than some other large organizations. We have a very, very strong Partners in Health globally individual donor base. We hope because both people like the mission, and we hope that we do a good job around stewardship and keeping our donors involved. But we did have cutbacks, certainly globally as well. Um,
Mhm.
I think, amidst all that, it's how do you restructure and think about doubling down really on the mission? And I think that's, in times of crisis, if you believe in the theory of change, if you believe in the mission, one of the best ways of addressing that is doubling down, serving the people that you serve. One other advantage that we have is that, our leaders in the organization are the executive directors of all our countries. So, the executive director of PH in Rwanda is Rwandan. The executive director of PH in Malawi is Malawian, and on and on. And so they know deeply their country context. They know deeply that if we have to make hard choices, when sometimes we do, they're the ones that make those decisions because they are in closest proximity to where the work happens. But I would never say that, PIH has any. We're very fortunate and thrilled that we have a very, very loyal and continuing strong donor base. But there are many organizations that have done amazing work that have had to, um, yeah, also make really, really hard decisions during this time. I think we've had to make fewer from a percentage of budget situation. But the one add-on to that is because we work so closely with governments, and our job is really to support ministries of health in all these countries. Those ministries of health have seen huge hits to the resources they have, and they are asking us in Liberia, in Sierra Leone, in Lesotho, in Rwanda, in Haiti to do more and more and more. So just because we weren't a direct beneficiary of as much funding, we are still having to make many, many, many hard choices about what we can do and what we can't do for the ministries of health that we support, and we would love to do so much more. But there are hard choices being made by our colleagues every day.
Hmm. And have you, changed the way you look at your donor base as well? Like, have you made any changes operationally?
I think from PIH Canada standpoint, just working in Canada, we are continuing to try to become better known, and we can talk more about that. I think from a
Mhm.
global standpoint, knowing that U.S. opportunities are more limited, we are certainly looking for what other global avenues um, can we try to reach out to, communicate with, be in touch with. But I think the reality is that there's no combination of funders, there's no individual funders that will make up the damage for kind of cutbacks from the US in particular, but also from Canada, from the UK, from France, from many, many other countries, all of whom have slashed aid, which only makes the importance of supporting this push for debt relief, structural adjustment, tax avoidance that much more important. If we address some of those issues, it would give many more resources to ministries of health and governments to be able to do the work that they are responsible for doing. That right now, in many places, they have their hands tied. So we need to do both those things at the same time.
Sure. Okay. And in your like, just to expand that a little bit, like, do you think there are things which are different compared to 5 years ago? What you will like to know about your donor base today or your donors as is?
Yeah, I think we can always go deeper in. So I think it's a little different. The Partners in Health Global, which the majority of the funding has been from the US.
Hmm.
And I think in Canada, as you say, we're much younger. And we're very small. We're only a team of 13 people. And so the level of sophistication of our database is something we need to continue to expand on and really understand both who our donors are from kind of using data and understanding, what channel they came in with, what things do they enjoy receiving. And
Hmm.
also that can give us an indication, I think, of where are some untapped communities that might be receptive to our message and communication if we can learn um, from the kinds of people that are already supporting us. So those are two things I think we can do even more. The one thing that we often get asked by many people is, how can I help? Apart from giving money, what else can I do? And I think in Canada, one of the best things people can do for any organization you support, and certainly for Partners in Health Canada, if you believe in the work and in the mission, you can tell a friend, you can tell a family member, you can tell other people, I believe in this because whatever it is that resonates with you, can I introduce you? And we are always thrilled to chat with people at a $10 a month level, at a higher level, at any level, because the other thing that we're building is we're trying to build a movement for global health equity. And so if we ever have a hope of convincing the Canadian government or other governments that we think it is in our interest, as well as the global interest, to increase foreign aid funding back, we're not even anywhere close to the zero point 0.7 target that Lester Pearson first put out many years ago, over 50 years ago. Um, but the way that we can do that is by building a movement. So we're working a lot with students across the country. We're building student chapters on university campuses in high schools because that's the next generation of global health leaders. And I think, the youth are growing up in a context of supposed scarcity when people are telling them we have less and less and less. And I think we need to be pushing back and saying there are more than enough resources in the world to do a lot of good things that we know need to be done. And there's a huge question about allocation of resources. And those are things that are decided by people. It's not magic. And so if we're considering what money do we have for global health, that consideration also has to include the money that we're spending on fighter jets or the money that we're spending on tax breaks for the very wealthiest of our society. that's within the pool of consideration. Um, and so I think that movement for global health equity is starting to talk about some of those things, encouraging people and showing what can happen when we do invest in strong health systems, both from a productivity side, from the health of children, um, from employment, and that we can really accomplish a ton. And I think the students that we work with are incredibly motivated, incredibly passionate, and incredibly smart. And they're going to be our biggest champions. So that kind of outreach and engagement and tell a friend, tell a family member, tell your son or
Mhm.
daughter, it's what's going to get us to a better place.
That's a great idea for a campaign as well.
Absolutely. Yeah. Yeah. We need to keep trying to do that. We call super fans is kind of
Hmm.
a term we've sometimes used about people that, again, with the data that they open a lot of emails, they're always respond, they're with us on webinars, and kind of identifying those people who we know are really, really bought in, and how do we really make it easy for them to spread the word because we know that they're already really passionate about what we do, like we are. And so those are things that we're continuing to try to enhance and work on.
Hmm. So one of the things I also found as I was researching, PIH Canada delivers, I think, about 79 cents of every Canadian dollar raised on two programs. Charity Intelligence rates you at 4 stars. The ratio doesn't happen by accident.
Mhm.
Um, where do most peer Canadian charities leak, and where did you decide not to? I'm sure you must be doing something differently with a small team, as you said, and a global mission.
Yeah, I think certainly we want the most money that we can to go towards programming. We want the funds that people give to us to wind up in the hands of to pay salaries for doctors and nurses and to pay transportation for the mother who lives 3 hours from a clinic, who really without the $4 that it will pay on the back of a motorbike or in an ambulance or not an ambulance in someone else's car or the gasoline to get there, otherwise would not access care. So those dollars make all the difference in the world to saving lives. I
Hmm.
think at the same time, there's a compelling argument that that fundraising and min ratio can be deceiving. Both if it's too small, then I would say if an organization is spending only 2 or 3 or 4 cents on the dollar on fundraising and administration, could they multiple their impact by 4 times if they spent a little bit more, right? If we already have a bunch of donors, then maybe it's a really good thing to invest in a person who's a great communicator, who can talk with more potential donors, because that will enhance our fundraising. And for the point being, it will enhance our ability to provide more care for patients. So really focusing on what's the impact of the
Hmm.
dollar that people we give. I think we're doing a new strategic plan for PH Canada right now, and one of the things that we really want to focus on in that strat plan is how are we communicating the impact when people give or may decide to give us $100 or $500 or $10,000,
Hmm.
um, because that has a direct impact on us being able to provide healthcare and advancing health equity. If we can communicate that story, I think that's going to be more important to our success, whether we're spending 10 cents on fundraising or 12 or 14, because we're going
Hmm.
to really, really be increasing the pool in a way that we need to in order to actually deliver on the care that we need. Everywhere we work in certain districts and countries, and right beside where we work, there are people that aren't getting the level of services as people in the catchment area where we work. And for example, we have a hospital that just opened in rural Sierra Leone, a maternal center of excellence, which is providing the highest quality of maternal care that you can get anywhere in the world. And we are having people come from Liberia, from Ivory Coast, from Guinea, from all over Sierra Leone, because they have heard about the standard of care that will be available there. And so the goal of the global community should be no, people should not have to travel 10 hours or 20
Hmm.
hours to access care. So we can do it. We have proved we can do it. Let's ensure that other governments and organizations have the capacity in the model to also replicate a system that we know can be effective. And that's really why we think every dollar that we raise is leveraged, because we are documenting the impact. We are proving that it works through implementation research. We are using advocacy and policy to encourage organizations like the WHO, um, like many other organizations, to replicate models that PIH has developed. And we think that's going to be really our largest impact.
That's amazing. And if I was to give you that opportunity right now, like 100, like what will be your, what would you like to communicate to that donor who may have donated $100? Like, how did that money spent on actually achieving the mission?
Yeah. Well, one way $100 can go is in any country we work. That can be well over a month or a couple months of an honorarium for a community health worker. And so community health workers, as you said, are the backbone of our work. I'll put in a plug for a documentary film called Bending the Arc. So if people go to phcanada.org, and on the top right, it'll say watch the movie. You can watch it for free. But there's a scene in there where community health workers, or there's a bunch of scenes where people, you can see the value of community health workers. These are people of and from their community that they serve. Many of them initially, and still are, they were HIV patients or TB patients. So they are people who've received care, and they are out in communities accompanying and encouraging and supporting their neighbors, their community members, um, to do what it takes to receive treatment. So both don't give up. The notion of when you're sick and when you don't have a lot of money, despair is a real, it's as much of a challenge as anything biomedical going on. Community health workers do that kind of support. They also accompany patients to health centers. Um, we have a project that was actually supported by the Canadian government that was wonderful in Sierra Leone. We were providing very small incentives for traditional birth attendants who served a similar role, but their job was accompanying women to deliver in their homes um, for pregnancies. And of course, for most women, things will probably work out okay. But for many, many, many women who have more complicated pregnancies, they won't. And so we were incentivizing those traditional birth attendants with small honorariums to, instead of delivering in people's homes, accompany women to hospitals and health centers when we
Mhm.
ensure that those hospitals and health centers have the proper staff and supplies and their dignified spaces that people actually want to come to, then we see dramatic reductions in maternal mortality. And so that's what $100 can do, is help that community health worker do their work about ensuring patients can access the health system and addressing kind of social determinants that will often get in the way of that. And as you said, they're the bedrock of everything we do. Um, One of the reasons I'm so appreciative of this is because we have a chance to talk about these issues. You can't tell this story in a 20-second
Yeah.
infomercial or a really quick hit sound bite or a quote in a newspaper. And so to be able to tell the story of what it means to build a health system, it takes time, but that's also why we hope and we think we know from our data that once people give, our retention is much, much higher than industry averages because people start to really understand the model and are attached to it.
Yeah. And the truth is, like, most people love to help others,
Yeah.
right? And one of the things I tell our team, because we primarily serve nonprofit organizations, is, it helps us bind and connect to the mission, and say, there's nowhere else, you're sitting at your desk and you're making that kind of an impact because you're helping these organizations make an impact. And I think that certainly gives, especially like personally on a personal level, it gives me the purpose, because I'm not directly in Haiti helping people, but if I help PIH Canada, that's a way to help somebody in the community, and I think if more people start thinking like that, I think the world is definitely going to be a better place. So,
Yeah.
so that. it just helps, gives everybody a purpose, whether it's a developer, whether it's a tester, whoever is doing a very different kind of work.
I think that's so true. And one of the things you mentioned Paul Farmer at the beginning, and there's a book called Mountains Beyond Mountains that
Mm,
many people have read that kind of tells the story of Paul and the early years of PIH. And many people often, would say, "Oh, I can't do that," or "No one can do that example," or "That's, how are we supposed to live up to that?" And Paul passed away a few years ago, tragically. But for many years, Paul would say, we would all say, and Paul would say, "No one's asking you to do that, right? It's not about replicating what anybody else is doing." What Paul
mhm,
did ask is say, whatever you're doing, all of us can give 3% of our time, can give 5%, can use whatever skills we have in some small way to advance equity, to advance justice, to advance, um, the kinds of things that make us all smile and feel good. And I think there was another, in that book, there's a section that tells a story of one of the co-founders of Partners in Health, a philanthropist named Tom White. And Tom White was, a philanthropist, a very successful businessman in Boston who had made a lot of money. And at one point in the early years, he was talking with Paul, and he said, "Oh, I think I'm just going to give all this up and go with you and work in Haiti." And Paul said, "In your case, that would be a sin." And we're not a religious organization, but that was the phrase. Why would it be a sin? Because he had resources to give.
mhm.
Um, and we all have ways based on what we do that we can contribute. And without Tom's generosity and giving his resources, Partners in Health wouldn't be. So we should never, ever, ever, minimize the contributions that any of us can make here. We're not saving anyone. We are not leading anyone. We are not saying what should be done. But that doesn't take away at all from the fact that, yeah, we can contribute to saving lives in a big, big, big way. And if that can make us all feel good, knowing that we are giving other people the tools they need to do what they need to do for their country, for their people, at their direction and their decision making, then we're doing some really good stuff. And I think it's valuable.
Very true. Yeah. Did you get to meet Paul as well?
Yeah, yeah, we kind of a lot of people within Partners in Health. He was just such a magnetic person, obviously a brilliant physician, a brilliant thinker. But again, we talked in the beginning about relationships, and one
Hmm.
of the things that made him so, so special was he treated everybody like they were the most important person in the room. And I think he could go sit with presidents and prime ministers and heads of this and heads of that and be comfortable. And he could go be on a phone with a rural farmer in the middle of nowhere, Haiti, and be equally comfortable and happy and joyous and as engaging. And really, that's where he was happiest, being with patients, being with students. So, yeah, many of us had a privilege of working with Paul for a long time, and the lessons that many and inspiration that many of us, everybody within Partners in Health, takes from the example that he set. Um, I think that's going to live on, and that does live on in Partners in Health.
Absolutely. Now, I know behind PIH Canada's donor experience, behind your program reporting, behind advocacy, I know there's that whole infrastructure that kind of holds everything together. So, what's your view on how the Canadian charities, your size, should be thinking about that infrastructure right now?
Yeah, I think it's a really great question, and it's funny because we find ourselves still in that process of
Mhm.
of trying to figure out how much resources can we commit. And it was really around the discussion that we had before. We know that if we had um, a couple other people that were really on staff, expert in our database, could really segment the information that we have, could help us understand that when people come into the organization or when we have interactions, exactly what we need to be doing. And we think we have a pretty good sense of what we should be doing. But at the same time, we aren't dedicating as much as we would like to be, purely because of our size, because of the resources. So I
Mhm.
think it's for us. It's really about how do we ensure that what we are doing, we're doing well, I think is one thing. So do the first line of things really well. We have to ensure that we, know when people donate and that we are going to get back with a thank you for your generosity and solidarity really quickly. Treat people as they want to be treated, and that's respective of the incredible commitment that people are making. I think the second thing that well, there's many things we're always thinking about, but one is, if we put something out into the world, a survey, a question, a request, or what do you want to see, or how do you enjoy us interacting? We have to have the ability to be able to deliver on that. So the notion of whatever information we're collecting and recording and storing, if we're actually serious about building relationships and treating people as they deserve to be treated, it's not about extracting information that can't then be used to provide people with the kind of experience that they want and they need. And I think that goes right from our donor journey on our website to the kinds of communications that we give people. Obviously, people have many different preferences about what they want to receive, how they want to receive it, what kind of communication. And I think it's on us to continue to ensure that to the best of our ability, we put in our data systems that kind of match up with our human capacity. And I know obviously AI in certain ways will help us all do different things. And to match that up so we're actually delivering on what we say we're going to do.
True, and that was why my next question about, I know AI is starting to reshape a lot of how we function, and especially with smaller organizations, giving them capabilities, you had never before. So, question, how are you exploring AI yourself at PIH Canada? What are you cautious about? What are you curious about? And where do you think the sector is going to adopt it and going from here?
Yeah. Yeah, it's a big question, an important
Mm.
question. I think one thing, is to always keep in mind kind of the broader. I don't think any organization can, certainly in the charitable sector, where it's really important for us to raise as much money as we can because the impact of those dollars, as we talked about, can change lives, can save lives. And so it's on us to use technology in a way, if it will help us do that, in a way that's ethical and sound. So I think there are certainly ways we can use to analyze the data that we do have. Um, I think we are still exploring what that looks like. I think there's, within all nonprofits of a certain size, there is a research team that is really kind of how can we understand who our donors are, what kind of people might be interested in our organization. I think AI can be useful there. Um, we have also set guidelines on, and we're still in the process of developing guidelines. One thing we put in place internally is that we will use AI internally for things that appear internally.
Mhm.
Nothing that we share externally will be AI driven. And so that's kind of a hard and fast rule we have. The things that people see, that donors see, that our interaction will be person to person, driven by people. And so I think that's kind of one fundamental. And I think the tensions about, what different companies are doing, um, the environmental impact of data centers. I think there are lots of equity concerns about AI, and those affect the populations that we serve. So often even around various, I think many fundraising organizations have gift acceptance policies around
Yeah.
what kind of organization will we work with or what kind of money will we accept. We're an organization that in many ways we think those decisions should also be, if not in full part, at least in large part, driven by the people closest to the patients, because they may have very different views than someone sitting here in a setting of relative privilege in Toronto. Um, so who gets to make the decisions about use of AI? It should not just be those of us sitting here. This has to be decisions that also take into account, um, the people that we say we're here to serve, patients, clinicians that work closest with them, the leaders there, and how do we integrate kind of all those different perspectives, things that we may not even thought of. I think there's also a lot of implications of the use of AI in healthcare. Um,
Yep.
how do different biases that are built into AI because it is really trained on assumptions that have been prevalent in society, how do those biases positively or negatively impact populations that we serve? So
Hmm.
the best thing that we can do is kind of understand hopefully some of the questions and then really lean on some expertise about people who are doing some deep thinking about this to help really inform the decisions that we make as well.
That's quite right. And one of the things we are advising our clients is the data privacy. I think is important. I think you mentioned about keeping it internal. Like even if you're using it for external things, making sure human in the loop, like making sure you're reviewing what is being put out there, which anyways we have been doing for decades, for ages. Now it's just the machine is creating the output, and it has a tendency to hallucinate. Uh,
Yeah,
but yeah, I think there are opportunity areas like predictive segmentation, especially when you start
right.
looking into your donor base and say, okay, can we use it for generative outreach? Like, because yes, you're building relationships, but the data can sometimes help you strengthen those relationships and nurture those relationships as well, automate a few things as well. So
Exactly.
that's where we see, there are some opportunities there. Um,
Yeah.
I don't know where the time is has went. It's already close to the time, but a couple of quick last questions. One,
Yeah.
if a CEO of a mid-sized Canadian charity is listening to this, what would be your message to them, especially in these times?
I think one would be the most important asset that we have is our staff. And I think, certainly during COVID, in the sector at large, there's often a lot of turnover. And when you invest, hopefully, we really want to both invest in people and both try to create a culture that where people want to stay, where good people want to stay. And we can still do a lot more in that area, but the place where there is a limit is always on salaries, and we can always try to do more and try to do better. But given that at some point we can't compete with the private sector, so other ways of competing in terms of ensuring that people have really strong job satisfaction, in terms of people have not just ownership of their area, but input and ownership into the organization as a whole. I think we're having a lot of conversations about our strategic plan now, and that's a large part of it. Is really, people want to know what everybody in the organization is doing and where the organization is going, and I think that's an amazing thing because it says there's a feeling of collective responsibility. And so I
Hmm.
think to the extent that leaders can be as open and transparent and share as, overshare as much as possible. I hope it's something that we do. Hopefully that builds trust and protects your most important asset, which is, one, your employees. And then I think I guess the second piece on the donor side, let's take for granted that the work is strong. Without that, hopefully that there would be many changes. I think we're confident that the work is very strong. But I think on the donor side, it's really paying attention to relationships,
Hmm.
and I think that goes all the way from people that, um, how do you build relationships is that people feel like they're part of a family. And I think it's easier probably for small and medium organizations because the people that invest early really do become the family that helps drive the organization. And as you get slightly larger and slightly larger, how do you ensure that that really remains the core of what you do? Because I think it is possible to become a large organization and retain kind of the values of we appreciate all gifts. They're all incredibly important. And someone who's, open to making an introduction or to coming and volunteering that kind of thing not just brings in support to the organization, but provides inspiration. There's going to be a lot of rough days, and we've seen it in kind of the international sector as you say, over the past year. What keeps people going? And the things that keep people going can be really, really small things. I think the more that we can focus on creating a culture where people feel like they want to be somewhere, and they believe in the mission and they believe in the people that you're with every day, that's really, really important.
Yeah, I think you covered it all, like staff and donors, two big stakeholders for sure for any nonprofit. Mark, thank you so much. That was a serious conversation. I appreciate the time and candor. Uh, the thread I'm going to be thinking about after this is how you draw the line between the mission, the staff, how you make that happen, and the donors. And most of the conversation our listeners have inside their organization sometimes look at it as multiple problems. So it's been really insightful to talk and learn more about how you have been doing all of these things at PIH Canada. If today's episode was useful, share it with one peer in the sector who needs to hear it. Subscribe so you don't miss the next conversation. And if you want to learn more about Mark and his team, the work Mark and his team are doing, head to pihcanada.org, where you can find annual reports, programs, ways to support. All of it is there. Once again, Mark, thank you so much for doing this. And again, I'm Ashish, hosting ideaXchange, and we'll see everybody in the next episode. Thank you, Mark.
Thanks, Ashish. That was a lot of fun.